Yes, sir.
వస్తుందా?
Yes, sir.
వస్తుంది. ఇప్పుడు వస్తుంది.
Yes, sir. Submit.
వస్తుంది.
Yeah. Morning, everyone. So I'll be continuing the musculoskeletal system. I'll be talking about SLE. So it is a chronic systemic inflammatory disease, mainly dealt with production of autoantibodies. Mainly ANA is the most common autoantibody. Anti-dsDNA is the other specific and more common autoantibody. So it also this deposition of immune complexes in multiple organs like kidneys, lungs, heart, multiple organs causing pneumothorax, pericardial effusion, pericarditis, myocarditis. In the lungs, it can call pleuritis. Okay, and in the kidneys, glomerulonephritis. Okay, so all those are more common, and women are more commonly affected than men. So it is the most prevalent form of lupus, SLE. You have discoid lupus, subacute lupus, and drug-induced lupus. What are the drugs most commonly causing? You have many antibiotics like nitrofurantoin, isoniazid, okay, and then hydralazine. Hydralazine is the common drug which causes lupus, drug-induced lupus. So females around three. The ratio is 3:1, around 20 to 150 cases per 1 lakh population is the prevalence and severity of disease mainly depends on gender and ethnicity. So gender, females more commonly seen. So there are many etiology. There are genetic factors. You have hormonal factors, then immunological, and as well as environmental. So what are the genetic? You have these genes are more commonly involved. You have C1q, C2, C4 deficiencies. So patients who are deficient in these complement are more prone for SLE. HLA D2, D3, and 8. So HLA D2, 3, and 8 are more commonly involved. So we have these MCQ HLA DR2, 3, and 8 is mainly responsible for SLE. Then MBL, IL-10, MCP1, these are non-HLA, and PTPN 22. IL-10, MCP1, PTPN 22. These are non-HLA genes. Environmental factors, you have many like UV light exposure. Patients who are exposed to UV light, you have flares. You have the flares increasing SLE, and even the Epstein-Barr virus. Then you have infections, and other female are more prone. I've already told. So all these like environmental and genetic factors that will lead to abnormal immune response, uh, which leads to activation of the B cell that lead to production of autoantibodies like ANA, anti-dsDNA, and T cells. It will lead to activation of C3 to C3A, and C3 that will lead to increased inflammation. The inflammation, what are the signs of inflammation? You have rash, mainly you call it as butterfly rash, which I'll talk about the rash in the next slides. So then if it involves the kidneys, you have nephritis. So then arthritis if it involves the joints, leukopenia, like CNS disorders, carditis, clotting disorders, and all these. Okay, so if that inflammation is prolonged, the chronic inflammation and along with oxidation, that will lead to complete damage like end stage renal disease, atherosclerosis, pulmonary fibrosis, stroke. So all these are the long-standing effects of SLE. If you're not treating here, then you can completely see the damage of all the organs, multiple organs. So ultimately, all these. So this is the main pathophysiology in SLE. So I've already told genetic factors. You have HLA-DR2 and HLA-DR3. Non-MHC, you have STAT4, PTPN22, and IRF5. So deficiencies of these complements C1q, C2, and C4a. So more responsible for SLE. Hormonal, high with estrogen containing contraceptives. So any females who are taking high estrogen containing contraceptives, they are more prone for SLE. So immunological loss of tolerance to self antigens. I've already told it's an autoimmune disorder. So they are less tolerant to the self antigens than environmental factors like smoking and Epstein-Barr virus, UV radiation. Okay, so all these are also responsible. So presence of autoantibodies and immune complexes, and these immune complexes will deposit in various joints like subendothelial, subepithelial, glomerulus, mesangial cells. Okay, so it will get deposited in all of these, and that ultimately leads to activation of the complement system. Then inflammatory cells could be seen in also in the kidneys, ultimately leading to fibrinoid necrosis, scarring, and renal failure. Okay, initially there is production of autoantibody and immune complexes. These complexes will deposit either in the mesangial, subendothelial, subepithelial regions, which will lead to activation of the complement system. That lead to increased activation of complement system leads to increase in the inflammatory cells, ultimately renal failure. So that's how the pathophysiology of lupus nephritis. So other associated conditions, it can be overlap with other CTDs like Sjogren's syndrome, even rheumatoid arthritis. So it can be, you can see overlap with other CTDs, or mainly like rheumatoid arthritis, primary Sjogren's. So Raynaud's disease, you have primary as well as secondary Raynaud's. How do you differentiate primary from secondary? Primary Raynaud's, they'll definitely have a family history of Raynaud's phenomenon. Okay, so ultimately what happens in Raynaud's, you see complete ulceration and digital ulceration, and also gangrene in the fingers. Okay, so more commonly seen in primary is more commonly seen in male, whereas secondary Raynaud's due to SLE is more commonly seen in females in the middle age, whereas primary Raynaud's is seen in younger age below 25 years. Okay, so that's how you differentiate. And ANA will be positive in secondary Raynaud's, negative in primary Raynaud's. So it could be also overlapping with systemic sclerosis, polymyositis, dermatomyositis. So all these also can be seen. So mixed CTD, when you call mixed CTD, positive ANA with high anti-RNP. Okay, so anti-RNP will also be positive in mixed CTD. That's how you differentiate mixed from SLE. So clinical features, most commonly, any middle age or any female who presents with fatigue and weight loss, fever, and immunocompromised status with increased predisposition to infections, and loss of malaise. They'll come with malaise and arthralgia, arthritis. So all these are also features. Okay, so lymphadenopathies also can be seen. Musculoskeletal, you have arthralgia, arthritis. Arthritis is always symmetric and migratory, and it is non-erosive. Okay, so fibromyalgias, myositis, myopathy, and osteoporosis. Osteoporosis is mostly due to the treatment. Give steroids. So the complication of long-term steroid is osteoporosis. So that's how a patient with SLE may present with. These are the musculoskeletal symptoms. So all these, even RA will have this arthralgia, arthritis. So even it is also symmetric and migratory, but they'll have more of early morning stiffness. Okay, and RA can be erosive. This is always non-erosive. Okay, so and the main differentiating factor is ANA positive in this thing, whereas anti-CCP is positive in RA. That's how you differentiate these two. Mucocutaneous, 50% of the patients, they have photosensitivity. So they're photosensitive, exposed to any UV light or sunlight, they'll have flares, increasing the flares. So photosensitivity is very important clinical features of SLE. They'll have malar rash. So these rash, how is the rash? They'll have erythema, and it will always spare the nasolabial folds. Okay, and it will be flat. It is very painful and reddish, and erythema. Usually it is not flat. It is slightly raised above the eminences, and will always spare the nasolabial folds. Okay, so this is about malar rash. You have discoid rash, and also oral nasopharyngeal ulcers. These ulcers are never painful. Okay, alopecia libido-reticularis, mostly in the lower limbs. Then vasculitis. So all these are the mucocutaneous clinical features. Okay, so GI signs, you have gastritis, mainly due to the drugs you give, like methotrexate, then steroids, so cyclophosphamide. All these are more prone for causing gastritis. Abnormal LFTs, so that's mainly due to the drugs only. Then anorexia, nausea, vomitings, infection, CMV, cytomegalovirus infections, abdominal pain. So all these are GI signs which you commonly see. Pulmonary signs I already told. Pleuritis. Patient mainly they have serositis. Okay, they'll have pleural effusions, pleuritis, pericardial effusions. So swelling of the limbs. So serositis and even the renals. So, serositis is one of the most common clinical feature of clinical sign of SLE. So, pneumonitis, thromboembolic involvement, and then shrinking lung syndrome. So, all these are the pulmonary signs. Then, cardiovascular, you have pericardial effusion, pericardial disease, pericarditis, pericardial tamponade, coronary artery disease, any valvular diseases. Liebman-Sachs enterocarditis is also very commonly seen in SLE patients. Myocarditis. So all these are the just whenever you're writing an essay question on SLE is asked. So that's how you write. You write the system wise, write the clinical features system wise, because it's a systemic disease. It will involve multiple organs. So better categorize into each organ and write it. So neurologic stroke syndrome, seizures, headache, neuropathies, CNS vasculitis. So these are more common neurological signs. So hematological anemia. Patient will present with pancytopenia, autoimmune hemolytic anemias. So direct Coombs test will be positive in these patients. Leukopenias, lymphopenias, neutropenias. So pancytopenia, patients will present with anemia. If you see it, it's pancytopenia. Then ITP, TTP is also commonly seen. Okay. So ophthalmologic, you have anterior uveitis, episcleritis, retinal vasculopathy, keratitis. So all these are the ophthalmologic features. So ACR criteria for diagnosis of lupus, you have 11 criteria. So the first one is malar rash, already told, discoid rash, photosensitivity, oral ulcers, non-erosive arthritis. It's always non-erosive, remember. Pleuropericarditis, that is serositis. Renal disease, that is proteinuria with or without cellular gas. Neurological disorders, like it could be seizures, psychosis. So this must be the neurological the cause of that should be, you should rule out all the other primary causes. Okay, so patient shouldn't have any like underlying stroke disorder or something. So hematological disorder like hemolytic anemia, pancytopenia. Positive LE cell preparation raised anti-dsDNA. Anti-dsDNA is very specific for SLE, remember. Okay, which is the most specific is always anti-dsDNA. Anti-SM present, false positive anti-treponema test. So then this is lab. All these three are lab. Okay, and then positive fluorescent ANA. Okay, so you call it definite SLE when any of the four are positive. Okay, so if four of these are positive, you can straight away label it as SLE and start the treatment. Okay, so you have to remember this table is this criteria is very important. These 11 you have to remember. Of these, the 8 are the clinicals and the rest 3 are lab. Okay, so which is the most common autoantibody? ANA. So 98% it is prevalence. Anti-dsDNA is 70% prevalent. Okay, but specific is always anti-dsDNA. Okay, so because there are many patients with ANA coming out not to be having SLE, because ANA can be positive in other CTDs as well, like rheumatoid arthritis. But anti-dsDNA is very specific. If anti-dsDNA is positive, most likely patient has SLE. Okay, but ANA is the initial screening test. If ANA is negative, most likely SLE is ruled out. Okay, so it's very sensitive. ANA is the most sensitive test. Anti-dsDNA is the most specific test. That's how it is. Okay, anti-SM, anti-RNP, anti-RO. These anti-RO, SSA, and these are most commonly associated with nephritis. Okay. Anti-LA, anti-SSA, SSB are more commonly seen in patients with lupus nephritis. So antihistone, then antiphospholipid, APLA syndromes, anti-erythrocyte, anti-platelet, these are less common. More common are anti-DSG, anti-SM, anti-RNP, anti-RO, and anti-LLA. These are very common. Okay, just remember the names, all the autoantibodies names. So imaging, the patient has chest pain, you have to do an ECG to rule out any coronary artery disease or any myocarditis or pericarditis. Joint pains, you do an X-ray of joints, it's always non-invasive. Okay, renal, you have to do an USG abdomen to look for the size of the kidneys and any irreversible or reversible damage. CNS, look for MRI brain, look for any stroke, any vasculitis, and then neuropathies you have to do for NCV. Diagnostic procedures. So if the patient has malar rash, you can go for skin biopsy. It's not usually done. Like if you see that the other criteria is not in going favor of SLE, you're not getting a diagnosis, then you can go for skin biopsy. Lupus nephritis, you have to go for renal biopsy just to categorize into there's 6 grades of lupus nephritis, grade 1 to 6. So for that, to categorize that, you have to do a renal biopsy. If the patient has lupus nephritis, that is proteinuria positive with cellular CAS and also creatinine raised, okay, with NA positive or SLE, typical SLE patient, you have to go for renal biopsy to categorize the grade of nephritis. Then serositis, pleural ascitic fluid analysis. Cytopenias, if the patient has cytopenia, you have to go for bone marrow analysis. That's mainly due to bone marrow suppression in SLE. Okay, joint fusion, if the patient has severe joint fusion, you go for orthocentesis. So treatment, the main treatment is always NSAIDs. The initial treatment is always NSAIDs, but if the patient has confirmed SLE and if it's involving all the other organs, you have to go for DMARDs. This is modifying anti-rheumatic drugs. Low-dose aspirin can be given for primary prevention of APLA. Okay, so aspirin low dose you can give for primary prevention of APLA. Mild disease, NSAIDs, HCQ can give to around 4 to 6 mg per kg, around 200 to 400 mg you can per day. So that's the dose. If the patient has mild, you can go with NSAIDs, HCQ, dapsone, low dose steroids, and topical steroids. Okay, so if the patient has mild, you can go with these low dose steroids along with hydroxychloroquine along with NSAIDs. If the patient has moderate to severe disease, so that means patient if it's involving lupus nephritis or any pericardial or pleural involvement, then you have to go for initial induction. So induction, you can go with high dose steroids. So the dose will be around methylprednisolone around 15 to 20 milligrams per kg, that will around 500 to 600 milligrams per day. So call it a pulse methylprednisolone, or you can go for 1 gram for around 3 to 5 days. Then once the induction is along with cyclophosphamide as well. Okay, so along with cyclophosphamide with high dose steroids. So initial induction will give. After induction phase, you can go for maintenance. So mycophenolate is also given to prevent mycophenolate is mainly given for prevention of allograft rejection. The patient is having like lupus nephritis, patient went for renal transplantation. Only to prevent that allograft rejection, mycophenolate is usually seen, or it can be used in patients who are non-tolerant to steroids. If the patient has side effects to steroids like severe osteoporosis, then you can go for mycophenolate. Azathioprine is a steroid sparing agent. You can use that as steroid sparing agent. Same like I said, the patient has severe osteoporosis or the patient has many complications for steroids, then you can go for azathioprine. Okay, so around 2 to 2.5 milligrams per kg per day is the usual dosage. So that's the usual dose, but usually it's not preferred. Preferred are always steroids with hydroxychloroquine. Methotrexate can be given if the patient has cutaneous and articular manifestations. If the patient has arthralgia, arthritis, then you can go for methotrexate. Dose will be around 7.5 to 15 milligrams once a week. So that you may give cyclosporin. Cyclosporin is not the primary line of therapy because it is highly renal toxic and hepatotoxic. So only if the patient is not responding with the primary treatment of steroids and cyclophosphamide, then only you can go. You have to go for cyclosporin. So this is rarely used. Cyclosporin is rarely used in SLE. Dosage is around 2.5 to 5 milligrams per kg per day. Okay. So cyclosporin is usually contraindicated. So lifestyle or risk modification, mainly what you tell the patients is avoid sun exposure. So because most of the patients will be photo sensitive, around 50% of the patients will be photosensitive. So you ask them to avoid exposing to the sun. So and also if they have to wear a sunscreen lotion to avoid any sun exposure. So sunscreen is very important management. Smoking, stop is smoking, you have to ask them to quit, and usually you avoid them to for any pregnancy if the patient is already diagnosed. Until the patient the inflammatory status is controlled, you ask them to avoid pregnancy. If all the patient is already pregnant, the safe drugs are always steroids. Steroids as category A drug, they can be used safely. You may also use azathioprine or and even cyclophosphamide also. Okay, these are category D drugs. But if the patient has severe other organ involvement like lupus nephritis in a pregnant lady, you can go for azathioprine as well. But absolutely contraindicated is methotrexate. Methotrexate is cat X drug, that is the risk will outweigh the benefits. So it is highly teratogenic. So even cyclophosphamide is also teratogenic, but if the patient has severe end organ diseases like lupus nephritis or pericarditis, pericardial effusion, you may go for azathioprine. But methotrexate is the drug which is completely contraindicated. Primary drugs will always be steroids. Okay, steroids, and you can go for hydroxychloroquine also. HCQ you can give if the patient has other organ involvement. So these are safe, but methotrexate is absolutely contraindicated. Okay, thank you.